So welcome back, those who were here yesterday. Welcome the new faces. Sorry?
Yesterday as well we attended.
Oh yeah. Yesterday we had too many people. I don't remember everybody. And yesterday I had the sound problem, so it was really frustrating and everything. So hi. So anyway, I'm gonna start now, and well, we can keep it interactive. So in case you have any questions like yesterday, just raise your hand. We can discuss, okay? So we're gonna talk today a bit about screw-retained solutions and mainly going to the prosthetic part. And including that, we need to discuss or raise a few issues about the impression technique that's really strongly related to that. So impressions, prosthetics is after the surgical phase. We had surgical phase yesterday. We're gonna have more detailed surgical phase tomorrow, and I will have colleagues in the afternoon, I think at 2 and 3:30 to talk about some surgical phases. So I'm gonna keep the surgery by now, but we can talk after that if you want detailed about. I think today we even have the implant engine here, so we can even let you place an implant if you want. So when you go for a restoration, once you have your implant also integrated, or you want to go right on for immediate loading, basically you have some questions related to your impression. One is whether you go for closed tray or open tray impression copings. If it's open tray, I will highlight it and I will explain why I will really push the splinted method, because I really think that's the way how we shall do, that's the way how it's figured out to be. Or we can also discuss the multi-unit question, but I think that's one extra option that you can have. Now again we have too many sound. I don't know what's happening again. Guys, what's with the sound again? Az előbb jobb volt, most nem tudom mi lett megint. Sorry, but now it's again too much noise in the background. Something is being changed. Anyway, when we go for the impression technique, the basic question whether we want to do cemented or screw retained crowns. For cemented, sorry. Ugyanaz van, mint tegnap. Tök jó volt a hang, és most belenyúltatok és szar lett. Tehát ne nyúljatok bele, létszik. Sorry, I don't know why they like to change the sound meanwhile I'm speaking. That's something, a challenge they want me to overcome. Okay, it's echo. Now it's echo. I had no echo before. You hear that? But it wasn't there before. When I started, there was no problem. I started and there was no problem with it. Okay, it's better? Okay. I hope it's not too much for you. We'll see. Anyway, so going back, screw retained, cemented. That's two big groups. They're really not related. So when you think about the impression technique, I think for cemented ones, closed trays are something you can use. There's a reason for why. You have the thickness of the cement, depending on what you use, 50, 70 microns at least. That's your playground. If it's not totally perfect, there's a tension, the cement will solve it. For the screw retained, you can't have that. It is what it is. It's screw on screw, it's metal on metal, it's tube on tube. It's fixed. So if you have tension, the tension will go to your implant. If you do a screw retained bridge with a closed tray impression, maybe perfect when you screw on, maybe a bit tight, and then after a few years you will see the resorption at the cortical level because you have tension at the neck of the implant. That's why we don't want to have it. So for the screw retains, it's mainly going for the open tray. We can have implant level impression or we can have intermediate level impression. I will explain what I meant in intermediate level impression. Closed trays, the system has different options. One is the T1D, T7D, different types of impression copings without plastic above. Or for other people who prefer that one, I myself really like the one with the plastic copings. It's really nice and easy. You need a bit more space mesiodistally for that because the plastic is thicker, but you can modify that yourself, but it works nicely. When you determine what type of restoration you want or you can have, it basically depends on implant angulation. Is your implant angulation favorable or not? If it's not favorable, you might think about a cemented restoration because there is angulation with that. You can solve. If it's favorable, good angulation, no problem with that. As I showed you yesterday with the digital planning, you can plan the position of the screw on the right point, so you can easily do a screw it and crown. Or if you have an unfavorable implant angulation or you do all-on-4 or something, you can have an angulated multi-unit in between that will solve your angulation problem up to 45 degrees. We're going to discuss that in the end. So as I told you, this is related to the impression method. For the cement retain, we can go for closed tray. For the screw retain, we'll suggest it to go for the open tray solutions. Just to give you exemplars, we're going to discuss them each by one, how they look like and how the impression copings look like for that. But we're going to discuss that in a second. So we had these. Closed tray impression, I think most of you who work with the system, you already did it. It's not a big thing, it's quite simple. We have the implant, we're going to put in the closed tray impression coping. Basically, the only thing we have to care about is it really fits tightly. In the US, the basic is you should do a periapical X-ray with the impression coping inside. To be honest, I not always do it. If I feel I'm really right in the implant, if I feel everything fits rightly, you don't have to do it all the time. But of course, it's somewhat better to have a, let's say, positive feedback that your impression coping is on the right situation. Actually, there's 2 X-rays requested. One is with the impression coping, second is with your framework inside to be sure everything is on situation. So you put on the coping. This is for P7. The P7D is orange now, but the theory or the whole thing is the same, and then you go for the impression. I myself prefer the 2-phase one-time impression technique, but doesn't matter. You can go for silicone, you can go for polyether, all can work, so it doesn't matter. Depends on your policy in the impression type what you use. Once you do an impression, the only critical thing is that you really have to wait until it hardens, and if you use a really, like I use A silicone, but the hardest A silicone modified M silicones for impressions, these are really hard. This means if I have an angulation problem between the implants and I would do a multiple case, I wouldn't be able to remove my impression. So I have to take care really about the angulations, otherwise I can get into troubles with that with a closed tray. Usually up to 20, even 30 degrees of angulation could be okay with removing an impression, but above that, angulation problem will cause you a problem with removing the impression itself. Once you remove the impression, you will de-screw the impression coping, screw it together with a lab analog, and then put it back. I suggest for all of you dentists to do it yourself. I never trust my dental technician to do that. Not that I don't trust his knowledge, it should be my responsibility that the implants are the same on the right situation. Moreover that, as you remember, we can have different gingival heights for the impression copings, 2 millimeters, 3 millimeters. If they mix up in the lab, the whole work is mixed up. So it's better for me remove one from the mouth and then go directly to the, into the impression. So put them together and directly into the impression. For restoration, for screw retains, we have a wide variety. You can go for the aesthetic abutments or zirconium abutments, or for temporization, the PEEK abutments. If it's individually fabricated everything, your technician can get any of the correctional abutments where you can basically form everything as your technician wishes. This is a very old case, but why I like it, it's a very difficult situation. We had one veneer next to it and normal screw cement retained crown, and we had issues with the papilla in the beginning because patient, as you see, didn't floss properly. But once everything is done rightly, it will nicely grow back and you will have a very nice soft tissue and red and white aesthetics. But depends on time and cleaning as well. Another case, I'm going to skip the surgical part. We removed the root. Obviously, we couldn't do anything. Maybe apical surgery could save the root, but we had no crown to restore. So implant in, temporization, and then final. After the healing time and osseointegration, soft tissue forming, and then going for it. That's what I told you. The plastic might give you a bit more space needed. What you can do, you can trim the plastic, not a problem. The only thing, it should be fixed in the impression. So when you put it on, it should go in without any tension, then sure it's on the right position. Again, screwing together and then doing the restoration. This time I do a screw retain. The only thing, or only situation where I think a closed tray impression could be suitable for a screw retain crown is a single unit. With a single unit, you don't have several implants in connection. You just have the teeth there, have anyway their resiliency, so it's not a big deal. So in these cases, you might think about doing a screw retain crown. I like to work with emergence profile, the double concave version, so really have a nice red and white aesthetics. You put in the implant, the soft tissue shall become white. It shall be staying white for the next 30 to 40 minutes. After that, the redness shall come back, then it's nice and then it's fine. But what we need to see is really nice red and white aesthetics. Sorry? Sorry?
It wasn't immediate loading.
No. The other era, what I told you, is for all the restorations where you have more complex cases, more implants related, as the open tray impressions. Open tray impressions are on the market since a long term, and to be honest, open tray impression is the impression method for implants. The closed tray, what they figured out long years ago, is only one thing. We dentists were used to do closed tray impressions. We were not used to doing the open tray. That's only for implants, because with teeth we were always doing this closed tray thing. But it's a different thing. Teeth are different, teeth have their movability, teeth are prepared, different shape, everything is different. For implants, it shall be open tray. We have literature on that if you do an open tray impression and you do splinting it with a jig, in Europe it's pattern resin, I think here it's called Duralay. You have it with a rigid polymer splint that you do, either you do directly in the office, or you can ask your dental technician to do it, cut it, and you just connect it yourself. It will be the way how you do. It can even work for single units, however it's more tricky because single units with open tray have the risk. When you put them together, when you screw together with a labanello, you can have rotation of the impression coping. So I prefer to do these tails on that or attachment to the neighboring teeth to be sure that we're really on the right position. Just a simple case. I take an impression, the technician is doing the jig, and I can connect myself. This is just a short video showing you how we do that. I'm using two different types. We have different types of open tray impression copings. The shape is different depending on where you have teeth next to it, how much space you have, what is the gum position. The main idea is what you need to do is just to build it up with this resin. You can use a dental floss in order to help you, or any other appliance what will connect the implants, just to put the liquid on the liquid powder solution on that. So I like to use poor quality dental flosses. Reason why? High quality dental floss has the wax on it and it's slippery in my hands. The poor quality doesn't have, so it's much easier to work with it. So you can easily do the connection without any problems or hassles. You do one by one, you use it as liquid. In the mouth, it's actually easier than in the model because in the mouth it's hot, so it's very quickly gets set. It's much quicker setting. Outside, when I do these models, sometimes they flow away, but in the mouth, usually it's easier. Anyway, whatever happens, you wait until it sets, and then you have to remove it. It is a must. If you want to do any type of open tray impression splinted, the basic is that you have to remove before the impression. Reason why? In case you have any torsion between the implants, there's angulation, and you're not able to remove it, this is the point where you could cut it and remove it without. If you don't do that, once the impression is on, you really will suffer. I was afraid earlier to tell the story because once I ran into that, I didn't remove, and then I couldn't remove the impression tray and had to cut off the impression tray. But then I told my father, who's a prosthodontist, and he told me he had the same story 35 years ago. So, not with implants, but with teeth. So I think every dentist in the life can do it once, not being able to remove your impression. Then you learn it for your lifetime. That ruins your day, and that ruins your patient's day. So anyway, what we do, yeah, that tray is an individually set tray. I can check you the brand. It's a German branding. It's for open tray impressions, metal, and you can remove section by section. I love it. Enormously expensive, typical German. Enormously expensive, but very good quality. Where we go back. In the end, if you remember me, I can check you the exact branding. They should be here. They were here 2 years ago, so they should be here somewhere. Not cheap, but I think it's worth. You have upper, lower, different sizes. Actually, 2 trays will solve most cases because it's quite wide, so depending on the arch, it could work. That's one option, to have these trays, or you can have the photopolymerization material for trays, that individual tray material that a dental technician can do. To be honest, I have it in my office. I have an oven for that, and I can do it myself, so I don't need all the time these trays. Once I removed with this screw, we remove it together with the impression, and then you will screw on the lab analogs on that. Critical, what I always suggest, if you never did splinted impression before, take a normal closed tray impression and take from the same case an open tray impression splinted. And then you hold the toe implant lab analogs, and you will feel the difference. In one case, they move separately. The other case, if you move one, the other one will move. The tension between them is zero, and that's what we're going for. Different open tray impression copings depending on whether you go implant level or we will do intermediate level. Intermediate level, what I mentioned, what is that? They are called multi-unit, but to be honest, we can also have it for single unit, but officially it was intended to be multi-unit. The idea is that you have this intermediate abutment or multi-unit abutment that you put into the implant. You put it on the implant level, and once it's on there, then you stop removing that. So once you put that in there, it's in fixed forever, and you don't want to remove that for any of the surfaces. So you change your whole situation, and you transform your implant to be, as they were before, external hexagon. So from that point on, we have the external hexagon situation. And then you work on that. You work on the external hexagon with a bridge, with a single unit. Obviously, for bridges, we don't need the hexagon, we just have the coping that will screw on that. For the single unit, you need the hexagon to avoid any type of rotation. This is just the case, single unit, and that I told you with the wings attachments on the teeth, neighboring teeth, to be exactly fitting. The lab analog will be different. As I transformed my implant before that already for an external hexagon, I will have my lab analog matching to that, so it will have the same external hexagon shape on that. And then we go for the crown. To be honest, I did a few cases with multi-unit, single units, not really what you need to have it. You don't need it. Sometimes it's good for angulation correction, but mainly multi-unit is for the bigger cases where you have several implants next to each other. Especially I don't like because we don't have enough space for covering the cover screw, so aesthetic might be compromised in the molar region where it's visible. Another case, there one bridge, one single unit. This is very critical. I did a first impression, closed tray. I sent to the lab and I asked the technician not to do the work. I asked them to do put 2 open tray impression copings and connect them. And he connected it in the lab, and when I put it in the mouse, it looks like this. This is the typical failure. My first impression somehow rotated in that. We did a study on that, and most complications with implants was the rotation of the lab envelope. However, you as a dentist don't face that, because when you do a bridge, your technician will remove the hexagons. So the rotation you don't realize. The only thing you realize is that one side of the bridge is on site and the other side is, let's say, slightly not there. Maybe you see it on the X-ray, but typically that is that distance that you don't see on the X-ray. You go for the X-ray and you see, is it on the position or not? Well, I don't feel it. I tighten. Oh, looks good. But you can never check, because that's like 20 to 30 microns. The minimal what you can detect is 50 microns. That's with your sharp explorer. Everything below that you don't see. So this is the way how we can avoid that. You see in the mouse, you connect it, and then you're sure there's no tension between your implants. Again, 2-phase 1 time. This time I'm using individual tray. I love them. You get these materials, these photopolymerization polymers, and with that you can do the tray even yourself. I hope I have a slide for that to show you. That's the framework. Still, again, we had one complication, but I like to show you the complications. The other side, the single unit, though it was having the tray, it rotated a bit. If I compare the stone model to the mouse, you can see there's a, let's see, a few degrees of rotation. Luckily, this is the stage with a try-in of the framework where you can take a correction impression. Basically, you take an impression and then you can ask a technician to correct it with the ceramics. For a single unit, it doesn't really matter. Yeah. Other options to restore is when you have the multi-unit. Basically, the critical with this system is that you have to have to match the multi-unit system to the implant system. So it should be always the color-coded ones help you a lot. The golden one goes for the conical connection. The metal or silver shape, they go for the regular hexagonal connection. Once you have the multi-unit in there, everything above is the same. The plastic, the moldable parts, the impressions are exactly the same because the outer hexagon is the same. You transformed it already. That's why it's critical to do it and reach the level once everything is transformed to the external hexagon. Other option is to do a full castable base. I suggest that for not so difficult and not big cases. Single unit, or let's say 2-3 units maximum. Why? You will directly go into the implant with the hexagon, and this time the hexagon is produced by your dental technician. If your lab is good, they can do high quality of this bridge. If your lab is not really good or not so precise, not working with loops, magnifications, not working with basically microscopes, then you might get precision issues. Or last is that when you have a titanium base or cobalt chrome base. I myself prefer the cobalt chrome base. Why? Because we use mainly that material for also the framework. So you can have a full casted material where the company has produced under its lab conditions the connection between the implant and the abutment, and everything else is molded on that. I will show you how that goes. I showed you this earlier. I will skip to there. Yeah. Simple case. Patient comes in. First orthodontics did some work. Then we have the implant. This implant wasn't really on the right position. I wanted to go more deeper. I corrected, but then I put the healing abutment. It heals nicely. After 3 months, remove the healing copings. Open tray impression with the wings on the teeth neighboring. I had to block it. I hate orthodontics, they always complicate my life, but anyway, they had the splint in there, so I had to do the blocking. Impression done with open tray. And then, these are the bases. Cobalt chrome base with the plastic. The plastic is moldable. Technician puts it into the model. He will cut back on the right angulation and position. do the waxing on that, so we have a wax form directly on that, and then easy thing to do from that, like a normal bridge. I won the lottery. Bingo. See you. Okay, so we do the plastic, we do the wax, and then normal framework burning. And what you see here, it's very, this shows you, you have the base that is not touched by your dental technician. That's exactly how the company made it, precise fitting in the implant. And then you have the head, basically the framework that is exactly done by your technician individually for the patient. I usually prefer try it in and take an impression with it, and also take a bite to see if I have enough space for the ceramic. I cannot expect my ceramics to do a nice work if I don't let enough space to have the ceramic covering. I really prefer porcelain fused metal for implants. Why? Because it works nicely. You don't have a problem. You don't need the zirconium in most of the cases if you keep the dimensions. If you have enough space for that, technician can really transfer it to a nice porcelain fused metal crown. Of course, it's nice to do the zirconiums and the CAD-CAMs, but most cases, especially molar cases, on a long term, 5 or 10 years, you will have much less complications with a porcelain fused metal than with having any type of full zirconium restorations. The other advantage of having the conical connection together with cobalt chrome bases, that these bases are so tight together with the conical implants that once you put it in, you screw them in, you remove the screw, and they will still be fixed. This means, I gave a try to that. Once I had the model, I asked for the framework, I screwed the model into the lab analog, and then I tried to remove it, and it's not coming out. That's a good thing. But you face that in the same as the patient. If you do the framework, it's not coming out. That's why we have a special retrieving screw where you go into the implant, you start screwing. I love that. You screw in with the retrieval screw, it will let the basically the framework pop out, and then you can remove it. You will see when it's moving. Yeah, now it's moved. So this is what you need to do. Important, you have to discuss it with your dental technician. I had a case, I tried to do this, it wasn't working. And when I asked the technician why, he said, well, yeah, I've seen that there's something, there's a bit of stone in the middle, so I just went in with a fraser and I cleaned it. And he ruined my internal screws. I was like, oh no. So discuss the technician. If they don't know this, they can ruin your life. Closing screw retained crowns, usually I use Teflon tape and then closing with any type of composites. I use opaque composites, AO3 or something like that. Simple thing, I just took a model to show you. I love this AO2 from GC, and my only rule, I always use one piece of Teflon tape. I put in the Teflon. If it's not big enough, I remove and put another one. Why? Because when the patient's coming back after 8 years, I never remember what I did. And when I try to remove it, and I remove a piece of Teflon, I have to know that the only piece of Teflon that's in there. It's not 2-3 pieces, because then I will have struggling. Sometimes you don't see at all. Ceramic can break, composite can wear, patients disappear for 8 years. So my only rule, I always keep that. I tried, I've seen they're back now, there was these silver plugs and everything. Works, but for me, the best what I can do is still the Teflon tape. It works for long term. I've seen cases more than 10 years from now, and all work nicely with the Teflon. So I really can suggest. None of the systems can promise you that you won't have, after 5 or 10 years, loosening of the screw. The idea is you have to be able to solve the case. If you can remove nicely the covering, the composite, and the covering, that means the Teflon, easy thing. So what you do, you tighten it with a ratchet, then you go with a Teflon, you go in, put it. I usually like to leave 1.5 to 2 millimeters of composite, not more, not less. You didn't need too much. I really push it. I keep these special burnishers, small burnishers, to really compress it, and then it's really, really closing it. And then we go for the composite. From now on, it's a simple class 1 filling. Bad thing, you can't charge your patient for the class 1 filling you're doing, but that's related to the implant. So you just go. I really like these opaque composites. They really hide away the metal. If you use a nice opaque composite from GC or other brands where it's really opaque, you won't have problem with the metal that's visible in the inside of the crown. If you want to use normal colors, they are too translucent, and with the translucency you might end up with getting this black darkish color. My experience, patients prefer lighter colors. So if for me it's anesthetically that I have a white spot on the middle of the tooth, my patient will be happy. If it looks exactly like the tooth, they're okay, but if it's a bit darker, they say, why is there a hole in my implant? So better do more lighter. Okay, when it's not a single crown, and we're heading to the end now, when we do a bridge, usually we can go for the multi-units. I think the best is to use, earlier there was the S6, S7 system, but now for single units you have with the hexagon, and for bridges you have without the hexagon. Now we're gonna more go beyond the S6 and S7. They were 2 pieces. I prefer the 1-piece system, that is the 1 multi-unit from S16 or X17. For the conicals, S16D, X17D. We have straight, we have 17 degrees, we have 30 degrees, and up to 45 degrees. 45 degrees is only for the I can't say all on 4 that's branded, but like everything on 4, let's say. So when you want to do the tilted implants. So I don't really prefer that. I will show you why, but it works. We have literature. Tomorrow we have a lecture about when and how, when you use 4 implants, when you use 2, when you use 6 implants. The all-on-4 concept is originally made for guides. So you need to have some guidance to have exactly the 45 degrees or exactly the 30 degrees. The idea is the 2 middle ones are straight and the 2 distal ones are tilted to avoid the foramen there. This is just a model. I wanted to show how that goes. It will be speeded up so you see what's happening. The two fronts are straight, the 2 laterals are tilted to avoid the nerve and to have as distal abutment for your implant as possible. Just widening a bit. If you remember drilling protocol, I do core drilling, 2 implant size less than the implant, then 1 size less, I just do cortical drilling, and then we go for the implant. Easily, front ones go in, and then the distal ones tilted will go in as well. The critical part is that you need to be aware about the angulation changes. The intermediate abutment, or let's say multi-unit, will solve you the angulation distance difference between 2 implants up to 30 degrees. So basically it will allow you up to 30 degrees, and then you can go for the distal ones. Those can be 30, 17 or 45 degrees depending on which concept you go for. The important is you should be one of these. You shouldn't have 25. That's not in the system, so that's really critical. Then this is the angulation, then we do the transformation. For the front ones, we're gonna do the S16, that's the straight one, and for the more distal ones, we're gonna do the tilted abutments, S17, exactly on that. This is again the situation I told you. We put in the abutments, and then once it's in there, we tighten it, and we shouldn't remove it. So it's critical you do the tightening and then you work on the intermediate level. You will put the healing abutments on that. There are special healing abutments matching these multi-units. Then you will go basically the impressions directly on the multi-unit level, and the final or even temporary will be on the multi-unit level. No other chances. If you remove, especially for the front ones, it's never the same. The front ones have no hexagon, the straight ones. So if you tighten more, it will be deeper. If you tighten less, it will more up. You're never precise if you let it removed. So I will skip this. What I told you, we have S16 in the front, S17 in the molars, and as you see, with the angulation, we have our final angulations. They're quite parallel. Don't have to be perfect. I told you we have up to 30 degrees in total from the last implant, the two more distal implants to each other. You can have 30 degrees of angulation deviation. Then you have your impression copings the same way with a jig. Put in that, take an impression. This is the tray what I told you. This material you can buy in any shop where they sell materials for dental labs. A lot of them are produced. I love the Italian ones. Very easy to go for. You get this material. When you buy it, it's flexible. You form it. You take an impression with a alginate. You make a stone model. You form it, and if you buy an oven that is usually used by the ladies who do the nails, I don't know if you've ever seen that. That's UV oven, exactly the same wavelengths what you need. So you put it into that oven. I have one of these nail ovens in my office, and you can do it in your office as well. You don't have to wait for the technician to sand it back. Sometimes because of time and I want to be quicker, I do it in the office, but when I'm lazy and the patient is not traveling away, I just send it to the lab and it's coming back, so it's less work for me. And then what I told you, we have matching healing caps, and this is how the whole situation goes. And then we have the bridge. This is the temporary bridge, put on the patient easily and solve the case. I'm not a big fan of all-on-4 situations. I will show you why. One of my colleagues is doing that all the time, so he loves to build it up. He shall be around, I think, today or tomorrow. Anyway, just another case. And I wanted to show you the critical part. This is a case where we had enough bone for 4 straight implants. I don't have to tilt them, but then the patient changed their mind. I wanted to have removable first, and the patient changed their mind and wanted to have the fixed. If I knew that before, I would have tilted them, but anyway, we still have enough force and space for that. You can go, there's literature on that. Distally, you can go up to 2 units without any problem. So that's not an issue with that. But if I knew before, I would tilt them because it might be better for the implants. This is the situation. This is what I get back from the lab. I let them cut it. I can measure gum height before. And this is the multi-units in the mouse. This is how it goes. I cut it before going into the mouse, or I ask the technician to cut it. I fix them, and then I just connect them with the pattern resin. Very quick, very easy, and reliable. Then we go for the impression, and we're gonna get framework and final work. Why I don't like it? It's nice, but cleaning is always an issue with the patients. We did an article checking, is there any bone resorption on the long term? And after the follow-up, we had the results similar to what we see in literature, as the critical point is the distal part and mesial part of the tilted implants, but still on a long-term bone resorption is not worse than what you can see with any other straight implant. So that's not a big deal. On the other hand, my personal experience is sometimes patient is not really going for that. Yeah, I want to skip that slide. There's a slide about when they don't clean it. So the problem with patients, if they don't know how to floss, how to clean under such a fixed bridge, you will end up with the same situation as they had before, losing their teeth or losing their implant. So with all these, even the fixed restoration, the all-on-4s, the critical is that you educate your patient and have recall first every 3 months and then every 6 months, so they do the maintenance. Otherwise, you get in trouble. Option B that we can discuss tomorrow is when we do removable. That's easier to clean, but understand the quality of life of the patient will be much less because patients don't really prefer removable dentures. So I think this is for summarizing the options we have for screw retainment. I think you see there's a wide variety, but it's up to you which one you choose. I myself really prefer in single unit cases and all the bridge cases to have the screw retained because of the situation. Vacation comes back, sometimes even just for the control, and I just remove the bridge and show the bridge to the patient. That's what's under your bridge. You see, when did you have your green beads? You see it's here below. It's shocking for the patient, but it can help you. And also, if you have any type of complications, chipping of the ceramic, patient falling on the ground, having something, you don't have the big problem to cutting of the bridge. You just re-screw it, take it away for a few days of the patient, and then you can deliver back without any issues. I think I could summarize what I planned for today to have the screw-retained solutions, and I'm happy to answer your questions if you have some. Thank you for your attention with my kids in the desert of Dubai. Thanks for the attention.